So do you guys have any it's a really excited, like, yes, I'm getting to start farm. Yes, okay. It's relief. All right, so any questions from the last time we met and talked? All right, fantastic. So what were we talking about before? What was the last thing we were mentioning here? What was the last thing we were talking about in this section? Aspirin, right? How does aspirin work? So it prevents platelet activation. How does it do that? Blocks cyclooxygenase, right? One or two? Both, right? That's important. And why does that prevent platelet aggregation? So you said TXA. What is another name for that? Thromboxane, right? So we know thromboxane is important because that helps with the activation of platelets, right? So if you block that activation of platelets through blocking thromboxane, then you shouldn't have any platelet aggregation occurring here, right? So that's why we like to use aspirin. And what's the preferential aspects of aspirin versus, say, like our NSAIDs as we see here? The reversibility. So aspirin, being an irreversible inhibitor of cyclooxygenase, is nice because, you know, for the lifetime of that platelet, and platelets usually last for around how long? Like 7 to 10 days, something like that. That's usually the average I typically see. 7 to 10 days or so for the life of that platelet, and that cyclooxygenase is going to be inhibited, which is good. So that means you can take a relatively low dose of aspirin every day. And so as you generate new platelets, those will end up getting inhibited. And so generally, most of your platelets should be inhibited through that pathway. Obviously, platelets can still aggregate. You know, there's other accessory pathways, as we'll see here in a second, because you don't want to completely stop platelets, because then you run the risk of what? Bleeding, bruising, those sort of side effects, right? And so again, we mentioned with NSAIDs, those being reversible inhibitors, those tend to have more of a transient effect here. So you end up seeing issues where, you know, if you're on a really high dose of ibuprofen for that, you know, say 6 to 8 hour time period, yes, you might be at risk for bruising and bleeding. But with aspirin, that tends to be much more kind of long lasting sort of effect until those platelets, you know, cycle out essentially. So we mentioned some of the side effects associated, you can see with NSAIDs, and this kind of goes back for aspirin as well, because again, the mechanism is going to be the same. So you're going to expect the same sort of side effects. And why do you think we see so many GI side effects here? Yeah, so we need prostaglandins because those help with what feature in the stomach? Yeah, that nice mucosal barrier, right? Because we mentioned the gastric acid is pretty rough on mucosal tissue. It can digest mucosal tissue just as well as it can into the food you're ingesting. So if you didn't have that nice, more alkaline kind of mucus barrier there, which is in part generated through things like prostaglandins, you end up losing that. You lose that barrier, and then you can have erosion of the gastric tissue. You can see things like ulcers form there. And again, a lot of times the first question you ask with someone who you suspect having peptic ulcers is, do you take NSAIDs, right? So one of the things you want to figure out, because it's one of the leading causes, at least drug-induced causes. The other big cause for peptic ulcer disease is what? Yeah, H. pylori. We'll talk a little about that when we get to the GI section. So that's the other thing you have to consider. Obviously, GERD, just because of those kind of aggravating symptoms there. And then the bleeding issue there. Certainly, the bleeding will happen on the GI side. So that risk, especially like kind of chronic high dose uses. And again, we will see that when you have non-selective NSAIDs, this is going to be a bigger risk for this. This is why we like to use what we call COX-2 inhibitors. We'll talk more about this when we get to the ortho section, but again, you don't want to use a complete COX-2 inhibitor that only inhibits COX-2, because you end up seeing some increased cardiovascular risk associated with that. So that was no good. So we didn't like to use those. So we still stick with our generally unselective ones. Do you guys know of any NSAIDs that happen to be a little bit selective for COX-2? Yeah, Celebrex. Yeah, Celebrex is one of the more common ones we think of. So here, over here, celecoxib or Celebrex, that one is going to have a little bit more selectivity for COX-2, which we said is that inducible version of the enzyme. That's, you know, so that'll be good for pain relief. You know, so for instance, my dad, like, he has kind of intermittent gout, and he takes Celebrex because, you know, basically taking high dose ibuprofen or other non-selective NSAIDs was really too rough on his stomach. So we ended up switching him over to Celebrex, and it ended up working a lot better for him. So just things to kind of keep in mind when you're thinking about some of the side effect profiles and safety profiles of these drugs.
Does that go for rheumatoid arthritis also, the Celebrex?
You could also use it for that potentially. I'd probably, like, for most patients, I generally would recommend starting off with like a non-selective one, because again, while we haven't seen with drugs like Celebrex that increased cardiovascular risks like we did with a completely selective COX-2 inhibitor like that Vioxx. If you ever go look up Vioxx, you'll see nothing but like lawsuits and things like that associated with it. You got pulled from the market because of that. You know, generally it's going to be a little bit safer from the GI standpoint. Okay. So there's a few other blockers that can work, and you'll see this used kind of hand in hand along with aspirin. There's one called dipyridamole or persantine when this is by itself, and then there's a combination product called Agranox. This one's not really used for cardiovascular protection as much as you see just aspirin by itself, but sometimes you'll see it for preventions of like TIAs or those transient ischemic attacks or potentially patients with stroke. This one's nice because it acts as a vasodilator, so it kind of helps with cerebral blood flow a little bit from that standpoint. And again, there's not like a ton of studies to support its use, but it's something you may see for some of your patients who either have a history of TIA or a history of, say, occlusive stroke or something like that. And so, it basically works by inhibiting adenosine uptake. And so if you prevent adenosine uptake into the platelets, they can't really produce ADP. And we'll see how ADP is going to be a really important activator for platelets as well in just a second here. So again, not something you'll see too often, but you may see it every once in a while. So the question is, what type of stroke did the patient have, right? So if you had like a hemorrhagic stroke, increasing your chance for bleeding, probably not such a good thing, right? But if the issue was more of an occlusive type stroke, then that may be an okay drug, right? So it would be dependent on the kind of etiology of the stroke, what type of stroke it actually was. But very good question, yes. Okay, so next we'll talk about other steps on the platelet activation. We mentioned thromboxane here, how aspirin can work. Next, we're going to talk about our ADP receptor antagonist. You guys heard of Clopidogrel, I'm sure. Probably talked about it in one of your recent cases, or Professor Gerke was probably mentioning it. Clopidogrel, anyone know the other name for that? Plavix, yeah, we'll talk about a few other ones that are going to be used, that are a little bit more recent entries into the. Basically, these drugs are going to be ADP blockers, adenosine diphosphate. So there's two basic receptors here. You see this P2Y1 and a P2Y12. Both of these are important for triggering activation of these platelets. You'll see that P2Y1 is going to be this pathway that will initiate some of the shape changes of the platelets. We mentioned that normally they're kind of this nice globular shape, but then when they get activated, they form those little like kind of podocytes and little legs and things that will help it to kind of aggregate with other platelets. That was one chain in the pathway there. And then we have this P2Y12, which actually inhibit cyclic AMP-induced inhibition of platelet activation. So you're going to find that while both these receptors are needed for kind of complete activation, we will find that most of our drugs are going to be selected for just one of these receptors. So blocking just one of them is generally enough to cause pretty decent platelet inhibition for the most part. We're also going to see that this will also help with things like direct inhibition of fibrinogen. We know fibrinogen is really important for kind of linking that glycoprotein 2B and 3A receptors together. We'll talk about drugs that directly inhibit that in a second. And then also with von Willebrand factor. We mentioned that's really important when you actually have kind of that vascular injury occurring, that collagen's exposed. Von Willebrand is one of those kind of initiating factors there for platelet aggregation. So a couple of drugs here. We have ticlopidine. This one's not used too often, and we'll talk about that. That's kind of our first ADP receptor antagonist we'll talk about briefly, and then we'll talk about clopidogrel, which is kind of used for a long time as kind of the de facto ADP receptor antagonist. And nowadays we have a couple of newer ones called ticagrelor or Brilinta, and then we have prasugrel or Effient. I just like to say ticagrelor. I think it's kind of a fun kind of mouthfeel for as far as drugs go. Anyway, not just limited to wine, you can also have it for drug names. But basically, you're going to find that these are kind of dose-dependent inhibition of platelets, which means a lot of these drugs, especially those that have kind of longer half-life, you'll see that will load patients, give them kind of a loading dose in order to get them up to steady state sooner. So a lot of times we're going to use these drugs. And did Professor Gerke mention when you use these most commonly? Yeah, so a patient who's going into the cath lab typically, especially if they're going to have like a stent placed or something like that, you'll typically start them off with a big load, something like Plavix, or nowadays they might either use Brilinta or prasugrel, depending on several factors. But that's one of the big cases where we see them use that. They'll give them a loading dose, kind of get them up to steady state, and then use maintenance dosing afterwards that the patient will be on for kind of more prolonged periods of time. And why do you think you need a platelet inhibitor when you're placing stents? Because having that metal there, having any kind of foreign object is going to be one of those things that can trigger off, platelet aggregation and cause a clot. So we want to prevent that from happening. That's why we usually will use these for a prolonged period of time after a stent's being placed. Anywho, so you're going to find that these are typically synergistic with aspirin. Another place you might see these being used as if the patient has a true aspirin allergy and they cannot receive that, they will use one of these instead as an alternative. So if you had a patient who normally would be like on 81 milligrams of aspirin a day for prevention of MI, things like that, then you could use these as an alternative potentially. There's going to be a little bit more bleeding risk associated with it, but again, if you're kind of weighing the risk versus benefits for your patients there, and so we can either use it to try to prevent stroke, MI, PAD, angioplasty, all these different places where we might use these drugs. So ticlopidine, again, we're going to find that most of these drugs are going to be binding specifically to the P2Y12 receptor. I mentioned there's 2 of those, but really we only need 1 to be inhibited to really have good antiplatelet effects. So that's the main one we're going to see being affected here. Again, risk for things like hemorrhage. We also can see some kind of blood dyscrasias like neutropenia. And then we also have this risk for thrombocytopenic purpura, thrombotic thrombocytopenic purpura, or TTP, happening here. This is actually kind of an autoimmune kind of condition, and we see that it was happening with a little too much, a little too commonplace for this drug for our sake. So when we had Clopidogrel come along, we'll see had a much lower risk of TTP occurring, and so this is why ticlopidine kind of got shoved off kind of the spotlight there. But again, mortality can be pretty significant, especially if we're not catching it very early. So because of that, we don't really like to use this drug anymore. On the other hand, though, we'll have Clopidogrel or Plavix. A lot of these end up being prodrugs that actually get converted by the liver, which is why most of these are given orally. And you're going to see that we'll get that loading dose. We'll get that hepatic activation when given orally, then it'll be kind of the active form there. Hemorrhage, again, is going to be relatively low. So again, what we're going to find with our other anticoagulants, things that are directly affecting clotting factors, those tend to have a lot higher risk for hemorrhage, and you'll see with these drugs that only affect platelets, but their risk is still there. And again, oftentimes when you have a patient going to the cath lab, you're giving them drugs like, these Atp receptor antagonists. What else might you be giving them? We can talk about that. So so if you say you had a patient going to the cath lab, in addition to getting a drug like this ADP receptor antagonist, what other things might they be given? Yeah, something like heparin, right? So when you include multiple drugs, right, there's going to be some synergy there, and that's why that risk for hemorrhage can go up. And so you have to kind of take each piece of it together to say, okay, well, what's kind of my overall global risk while the patient's on all these different drugs at the same time, essentially. But very low risk for TTP, so we don't really clinically see that too often. And other than that, it's a very well tolerated drug. So again, patient education wise, just look for bruising, bleeding. Sorry, I can't really talk this afternoon, but those are the main things you're going to be really looking for. Next, we have Pradaxa or Efient. Again, this is binding that P2Y12 receptor. Again, is also going to be a prodrug that gets activated enzymatically. And with this one, you're going to see that a lot of these newer ones like ticagrelor and Pradaxa, they end up having a little bit more kind of intensive antiplatelet effect. They tend to be a little bit more potent, and so because of that, they're starting to get preferred a little bit over Clopidogrel. Again, they're newer, so they're going to be more expensive, and so that can be factored into based on what your patient's healthcare coverage is and things like that. But see, more platelet inhibition, which also means your risk for bleeding would also be higher, right? So again, it's going to be kind of co-measured. The higher your platelet inhibition, the higher the bleeding risk is going to be associated with this. Some other kind of unique side effects you're going to see with this include things like hypertension, which you wouldn't necessarily expect just based on the mechanism here. You can have worsened hyperlipidemia, some headache associated with it. So again, for the most part, well tolerated, but just again, be aware of that bleeding risk. And then we have ticagrelor or Brilinta. This one's actually not a prodrug, but will also have active metabolites, right? So sometimes you can have drugs that are active by themselves, but then they can have metabolites that are also active as well, which can lead to either therapeutic effects or potentially toxic effects as well, as you'll see. So again, this one will also getting a loading dose to get them up to kind of steady state a little bit sooner. And again, also being recommended over Clopidogrel in a lot of cases due to that kind of increased platelet inhibition. And that major bleeding is a risk with these drugs, so you got to watch out for that. Some risk for dyspnea, and then increased uric acid concentrations, which again, not necessarily we do expect based on the mechanism, but something you might see. Yes, ma'am.
Would you use the Pradaxa over Clopidogrel, or would you still not, just because of the expense?
It depends on the patient's things like their insurance coverage. Like, is it something they're going to be able to continue on an outpatient basis that their insurance will cover it? That might be something that will you might be more likely to they, due to that increased potential efficacy, because it's more has more antiplatelet effect, perhaps it might work better for them. Having to bring a patient back in to restent them could be a lot more costly than it would be just for the drug itself in some cases. So again, it's going to be kind of a cost benefits kind of analysis there, where you're looking to see like, what can the patient's insurance cover, what are you going to put them on in those cases. Other things could be, if they have a history of major bleed, things like that, that might lead you to say using something like Clopidogrel might have a little bit less risk associated with that. So you're kind of taking everything into account when you're doing this. Okay, next up we'll talk about our 2B3A inhibitors. Remember, fibrinogen is going to come and is going to be a potent activator for this aggregation here between the 2B3A receptors, right? So before these cross links, a lot of them kind of stick together in one big nice mass. So a couple of drugs we're going to have here. So the first one we have is Apixaban. So what type of drug do you think this is? Monoclonal antibody, absolutely. So Apixaban or Riapro. These are so a lot of the ADP receptor antagonists are going to be oral medications, and those are typically drugs that the patients are going to stay on for more in the chronic cases, especially when they leave the hospital with a stent, or if they have, if they're allergic to aspirin, they can stay on that one the long term. These drugs here, these 2B3A inhibitors, these are going to be IV medications only that are going to be given for usually as a continuous infusion in order to get the patient through the surgery, and then they'll typically stop that, and they'll just be maintained on either aspirin or one of the ADP receptor antagonists, typically. And so what you're going to see here is, again, it's a monoclonal antibody, so you worry about what type of side effect associated with that. Anaphylaxis, right? So you worry about anytime you're given a foreign protein, you worry about having anaphylaxis, and so that can be important because imagine, a patient comes in, they get stents placed one time, what they might be at risk for later on down the road. Having to get stents again, right? So they can have another vessels that will occlude off and lead them to get more stents. And so again, you have to think about these patients, have they received Apixaban before? You have the risk of developing antibodies to this over time. So it may either find the drug to be ineffective or more likely to have that kind of anaphylactic reaction. So again, that's also something you might want to consider. What has your patient received previously? Might that be a risk for more kind of issues with it this time? So these drugs work very, very quickly to block off those 2B3A receptors, and typically they stay bound to those receptors for about 18-24 hours after the infusion is stopped. So basically you still have some increased risk for bleeding after that, but typically goes off in around a day or so. And again, because it's an antibody, it's going to be pretty expensive to make.
Yeah, so if you gave somebody this and then, like you're saying, they needed a stent again, you would test to see if they had antibodies developed against that?
There's not really a good test to see if they have antibodies against it, but it might be something where you're kind of giving it to them and you're looking to see is it being effective. You're looking for evidence of obviously signs of anaphylaxis and things like that. So not anything we have a good test for to look for antibody. If we did, it would be very, very expensive and not very cost effective for the majority of patients. Yep. A lot of this is determined also like what's on your hospital formulary. You usually have like one or two on formulary, and that'll be kind of based on cost and based on several different things, and so you'll kind of have a choice of one or two drugs, and say you might have Apixaban and one of these other ones. If they've received Apixaban before, maybe you'll say, well, let's hold off on that one, let's try this other one instead. They've received one or two times beforehand. So again, oftentimes you'll see it, in conjunction with aspirin and also heparin for angioplasties. Help to prevent restenosis kind of in that short term post-operatively, which is nice. Obviously, bleeding is going to be one of the big risks we see with this, and about 3 to 5% of your patients can develop antibodies against that. So again, repeated use, I don't know if there's any studies out there saying definitively when this actually occurs in the majority of patients, but it's a theoretical risk. Next, we have eptifibatide or integralin. This will also be an IV infusion. Note here, this is not going to be a monoclonal antibody, so you do not have that kind of anaphylaxis risk as you might see with one of those. Again, this is going to be, blocking that 2B3A receptor. This one you can see infusion. Sometimes you'll leave patients on it for up to, say, 96 hours or so, but again, relatively short term compared to things like your Plavixes or your aspirins, and where they may be on that indefinitely. Again, same clinical use. Again, therapeutically, these tend to be interchangeable for the most part. These 2B3A antagonists. Again, bleeding, thrombocytopenia tend to be the biggest risk. Less immunogenic than you would see with something like Apixaban. And then the last one in this category is tirofiban or aggrastat. Again, non-peptide, low risk for anaphylaxis we see with this one. And sometimes a lot of these decisions will be made based on organ function as well. So this one tends to be renally eliminated. So if you had a patient with poor kidneys, this might not be the best option for them. You might want to switch over to something like integralin instead, due to the fact that if you hold on to more of this drug, you run the risk of more toxicity, more bleeding in this case, right? That being the primary thing we're really worried about in those cases. So again, all of them are going to have very similar side effects. All of them work very, very similarly. Again, there's little kind of idiosyncrasies with each of them that might preclude you from using one drug versus another for a patient. Okay. So that's it. Those are the majority of the antiplatelet drugs you may see being used on patients. Up next, we're going to look at our anticoagulants, and these are going to be specifically focused on clotting factors, right? So again, looking at our lovely coagulation cascade, we're going to find that different anticoagulants are going to have effects on different clotting factors. And so that'll be important. And I'll kind of point out those cases where that is really important, because that will determine what type of monitoring you're going to use. So what are your typical clotting tests you run for most patients? PT, and then in addition to PT, what's that associated with? INR, right? So you have PT, INR. What else? APTT, that'd be another big one. You guys know any other ones? You guys ever heard of an anti-10A level? Ooh, it's going to be a new one we're going to talk about today. So that'll be important because depending on the drug you're using, you're going to be able to determine how effective that drug is going to be, either in regards to toxicity or subtherapeutic effects. We'll see based on which drug we're talking about, which test we're going to be using associated with that. So that'll be an important thing for on the test, because again, it's one of those things where if I accidentally give my patient a heparin overdose, making sure I'm actually monitoring the correct test is going to be really important there, because I'm looking at the wrong one. It may look normal, and the patient may actually be at very increased risk for bleeding in those cases. So we'll talk about those specific circumstances. So again, I'm not going to kind of belabor going through this whole cascade. Just know that generally you're going to find that a lot of the drugs we're going to talk about are going to be kind of affecting this kind of common cascade here, right? So a lot of them are going to be affecting factor 10. Factor 10 is going to be a very, very important clotting factor we're going to be inhibiting here. Factor 2 is also going to be another really important one as well, right? So by inhibiting either of those, you're going to tend to have kind of upstream effects as well, because you mentioned this is a positive feedback loop where a lot of these are going to feed back up higher in the chain and continue to activate that. So you get this nice kind of cascade. So right where the clot or the bleed is happening, you can form a clot very, very effectively. So we're going to try to interrupt that with these drugs. So you can see we also have kind of natural inhibitors that our body produces, because again, you want to clot kind of unchecked, because otherwise you'd just be a giant clot in your vessels and it wouldn't be very compatible with life. So we have things like protein C and S, which are kind of natural anticoagulants that will be affected by some of these drugs. Antithrombin 3 is a really important one, because what works with antithrombin 3 to help it have anticoagulant effects? Anyone know? It's a drug we're going to talk about. Actually works with heparin. So heparin is going to be a really important thing we'll talk about here as we're working with antithrombin 3. So there's several different things. We'll talk about these as we get into more details on the drugs themselves. Okay, so heparin, first thing we're going to talk about. Every one of you has heparin in your bodies right now, so this is going to be typically either animal-derived product that we're going to be giving, or potentially a recombinant product, depending on which type of product you receive specifically. But basically, it's a long sugar chain you're going to see here. They typically are very, very long, can be anywhere between 200 to 300 monosaccharide units long, so fairly big. You can see here the molecular weight is going to be fairly large as well. So we're going to see when we talk about low molecular weight heparins, these are basically going to be chopped up portions of regular heparin, as we're going to see. So kind of keep those relationships in mind. When you hear unfractionated heparin, this is what we're referring to. This regular heparin has not been chopped up. It is the original kind of long chain sugar molecule here. So what this does is antithrombin 3 is going to be basically an enzyme that is used to inactivate things like factor 2. 2 is going to be a very important one here. Factor 10. You also see 9, 11, and 12. Okay. So again, these are going to be the main ones we're going to get kind of the most bang for our buck out of, therapeutically speaking, but it will also affect 9, 11, and 12. So heparin will come along. It will help antithrombin 3 to work up to 1,000 times faster than it would otherwise, right? Antithrombin 3 has activity of its own, but with heparin coming along here, it will help it to activate much quicker. It will be able to degrade factors 2, 10, 9, 11, and 12 much more quickly and efficiently than it would otherwise. Now we're going to see that when you chop up heparin into those low molecular weight heparins, we're going to see that it will change its activity. It will only be able to affect certain of these clotting factors, as we'll see in just a little bit. So kind of keep that relationship in mind. But once they're inactivated, then obviously they're not functioning anymore. Thus, you're going to have an anticoagulant sort of effect occurring there. Okay. Once antithrombin 3 and the thrombin is bound, or factor 2 in that case, the heparin gets released and can go along and affect some other antithrombin 3. So again, this is something that can be recycled kind of over and over again. So if you had to imagine this is this long chain being unfractionated heparin here, you have antithrombin 3. You have basically this come along, and you have things like activated factor 10A. Notice this is a shorter molecule. That'll be important later when we talk about our low molecular weight heparins. You'll have activated thrombin, or factor 2A here. So kind of notice here how heparin's long enough to encompass both factor 10 and factor 2. So it'll be able to work for both of these, right? So again, it doesn't really discriminate between factor 10 and 2 necessarily, because it's long enough to be able to work with both of those. So you see that some of this is actually derived from porcine intestinal mucosa, or possibly bovine lungs. So next time you ever give someone heparin, think about that. It's giving them a pork-based product, potentially bovine. So again, we have all kind of interesting sources for a lot of these drugs here. Now, heparin itself cannot be absorbed through the GI tract, so this is going to be an IV-only medication, IV or potentially sub-Q, IM potentially. And so typically what you're going to find if you're treating someone therapeutically, meaning they actually have a clot already occurring, you'll typically give this as an IV infusion because the drug has a relatively short half-life. You have to give it via continuous infusion, and we'll see that we'll adjust the dose based on one of our clotting monitoring parameters in just a second here. If you're typically given for prophylaxis, meaning you're trying to prevent a clot from occurring, then you would give it typically sub-Q, typically like say like 3 times a day or so. So you can think of any cases where you might want to prophylactically give someone heparin to prevent a clot. Yeah, so surgery is going to be a big one, right? So if you imagine after surgery, patient is, especially if you imagine like orthopedic surgery, say they have like a knee replacement or a hip replacement, typically they're not going to be super mobile, right? So they're laid up in a hospital bed. Think about ICU patients who are, are intubated and sedated, and they're laying up for weeks to months at a time. What happens to the blood that's not being very, not moving around very much? Tends to clot, right? So we're really worried about things like DVTs and PEs that develop in those patients. So because of that, this is why we give prophylactic anticoagulants. Typically, heparin-based products are going to be one of the primary things we do. What are some mechanical things you can do to help prevent clots in those patients? SCD stands for? Yep, sequential compression device. So that helps to kind of pump that venous blood from the legs back into kind of the central circulation, so it doesn't just sit there and pool and potentially clot. You also have like compressive hoses and things like that. But this is kind of the chemical way we can do this is by giving them heparin essentially. So basically, you'll see that we'll give that usually 3 times a day or so, and that will help to prevent the blood from clotting and make it just a little bit thinner, so that way it does not form those clots and that's kind of static blood. If you had a patient who was, say, pregnant, though, if they were at risk for developing clot, which we know pregnant patients tend to be more hypercoagulable in general, or if you don't know that, you'll learn that when you get to OB section. But basically, the heparin's nice because it doesn't cross the blood-brain barrier, it doesn't cross into breast milk, so it's relatively safe for pregnant patients. So it's kind of another benefit to that. And so because it's such a long chain molecule, it's a really hard time crossing those kind of biologic membranes. And you'll typically see that the half-life can vary from patient to patient. It can go up if you have patients like cirrhosis or kind of poor functioning livers, if they have poor kidney function. So again, this is why monitoring is going to be super, super important for this, to make sure that we're not getting a patient too anticoagulated, increased risk for bleeding, and they're not too overcoagulated essentially, and more at risk for having clots there. So for monitoring, we're going to be measuring our APTT for heparin. Okay, so think unfractionated heparin, think regular heparin. APTT is the monitoring parameter we're going to be looking at. Basically, what you're doing, you're looking at the patient, basically a ratio here. You're looking at the patient's APTT in comparison to like a normal APTT control, and you're looking at typically getting about 1.5 to 2.5 times that ratio, right? So you want them to have a longer time to clot when you actually do that test. And so this is the main thing we're going to be looking for here. And so typically with heparin, it's relatively short acting. We'll go ahead and give a bolus of this. If you're, say we're doing this therapeutically and not just prophylactically, we'll give a big bolus up front. We'll get them up to a good APTT, and we'll do a continuous infusion, and then we can titrate that dose based on the results that come back. So a lot of times these are nursing-driven protocols where we'll say, hey, if the APTT comes back at this level, increase the dose by 10% or decrease it by 10%, whatever you have to do to get into that nice sweet spot, and then you can just leave your patient at that level for that rate for a decent period of time there. Okay. Main places we'll use heparin include venous thrombosis, pulmonary embolism, MI, coronary angioplasty. Any places where you need a patient to not clot, kind of in the short term, this is a really good drug to use for that, right? And it's a very old drug. It's one that we've been using for quite some time. So obviously one of the big risks anytime you're giving anticoagulant is going to be bleeding. And so the other important thing is, if you have a bleeding patient, the question is, well, how can I stop the bleeding, right? So it's important to know whether the drug you're talking about has an antidote to it, right? So this is important to keep these in mind, these relationships between which drugs, which antidote goes with which anticoagulant. Because again, patient shows up in the ER and they're bleeding out, you need to be able to stop that pretty quickly. And so it's important to make the right kind of decision on what to give them. So with heparin, we give a drug called protamine. Protamine can go along to bind up that heparin and prevent it from having any interactions with antithrombin 3. So that can help to bring your APTT back down. So if you were to accidentally give an overdose of heparin, if you were to accidentally get there, you give the continuous infusion, APTT comes back way too high, you can give them a dose of this to help try to drive it back down. So that is the antidote for heparin. This is specifically for heparin. This is the only one that's going to work with that one. This is where it'll be most effective, I should say. The other big thing, everyone ever heard of HIT before? Heparin-induced thrombocytopenia? You know what that is?
Decreased platelets with heparin use.
Yeah, so so basically you're going to see a decreased platelets. But the other thing is the platelets. The reason why they're disappearing is because they're all becoming active and basically causing clots kind of everywhere essentially. So this can be a potentially deadly side effect of heparin, and is basically a very rare thing, but something you need to be aware of and be able to monitor for. Basically, what you're seeing is that patients who are on heparin for a prolonged period of time, say 5 to 10 days or so, they develop an autoimmune reaction where basically they have antibodies that will form to both heparin and a product called platelet factor 4. And so when you have both of these come together, these antibodies, once they're activated, they will end up causing platelet activation and cause clots kind of everywhere. So you end up having stroke secondary to this. You can have MI, you can have all kinds of issues develop, and also thrombocytopenia because all your platelets get used up, which means you can have bleeding elsewhere. So it's kind of really kind of a nasty sort of side effect of this drug, so you want to be able to watch out for it. And one of the things we'll do is we'll look for if you ever like have a patient who's on heparin for prolonged period of time, you look for big drops in their platelets. That's one of the big things you'll look for. If you have all of a sudden platelets drop 50%, that's another sign that hey, we should probably stop here and kind of reevaluate and see what's going on with these patients. Instead, we'll actually give them an alternative anticoagulant. We'll talk about things like leparudin or gatrobane a little bit later. Actually, did I mention these already? Okay, we'll talk about these a little later in this section. Then I can't remember if it's over with the cardio or not. But anyway, we'll talk about these as alternatives that we can use in order to prevent to keep the patient anticoagulated without having to worry about giving them more heparin, which obviously is an issue for them. The other thing to watch out for is that with patients who are who had HIT, typically you do not want to give them any other heparin-derived products. That includes low molecular weight heparins, which we'll talk about in just a second here, and we'll talk about warfarin a little bit later on. Okay, so then if you were to say chop up your heparin into shorter chain molecules, you'll basically come up with what we call low molecular weight heparins. So if you ever hear that, that's what we're talking, or the LMWHs, that's kind of what they're referring to. Basically, these are going to be shorter units. They're not going to be able to affect the same clotting factors as heparin does. You're going to find that these typically have more activity for factor 10 than it did for factor 2. Okay, that's kind of the trade-off you have with these shorter chain molecules. They're going to be more selective for factor 10. The three ones we're going to have here include enoxaparin, dalteparin, and tenzaparin. I can say that I've never seen anything but enoxaparin ever being used, so I'm sure most of you have ever worked in the hospital have heard of Lovenox before. This is kind of the de facto low molecular heparin that a lot of people end up using. So their mechanism, we mentioned how a minimal effect on thrombin. I'll show you a picture why that is in a second. And because basically it lacks the sequence to bind appropriately with antithrombin 3 that will link up with that thrombin. But we'll have much more 10A activity that we'll see here. And so if you're looking at this ratio with like unfractionated heparin, say like 1-to-1 roughly versus low molecular weight heparin is about 2 to 4 times more selective for factor 10 than it is for factor 2. You imagine a low molecular weight heparin, notice this chain is a lot shorter. Basically, it doesn't really have the sequence long enough to really kind of facilitate this binding of antithrombin 3 to 2A, but it can work very, very well with factor 10A, no problem, right? So this is the main thing you're going to see a lot more activity for. So typically what you find is that with heparin, you really had to do it based off of, you'd have some kind of weight-based dosing you start out with. So for instance, like heparin's based in units, essentially. And so you start out with, say, I'm going to give them a bolus of 20 units per kilogram, and then I'll give them, say, 5 units per kilo per hour, and then you titrate based on their response. The nice thing about this is you don't have to do nearly as much monitoring with these low molecular weight heparins. Most of the time you just use weight-based dosing, right? Also, you can use both therapeutically and prophylactically, so you can use them basically therapeutically interchangeably with heparin. And again, the benefit is much less monitoring associated with it. A little more costly, but much less monitoring. So notice this will not have an effect on APTT, because what does APTT stand for? Yeah, activated partial prothrombin time, I should say. Again, I cannot talk in the afternoon typically, is why I usually schedule my stuff for 8 a.m. But anyway, because this is not really affecting prothrombin all that much, right? So again, we're not affecting thrombin, factor 2A very specifically. You're not, these low molecular weight heparins are not really going to have much effect on that. But we're going to have a different monitoring assay we'll talk about. And this is where we get this anti-factor 10A assay. This is going to be nice because it'll give you an idea of just how effective your low molecular weight heparin is going to be in anticoagulating that patient. But notice in most patients, you don't have to do this. You basically will have weight-based dosing. It's really easy too. You just say, like, for most patients, 1 milligram per kilogram twice a day. That's a therapeutic dose. I can just give that to them. Typically, this will be given sub-Q. And anyone know how enoxaparin usually comes? I don't know if anyone's ever seen it on the inpatient side. It usually comes as a pen. So basically, patients, it's very easy for their own home use. You can give them a bunch of these pens, and they can just inject it into themselves at home. Nice pre-filled syringes, so it's very convenient for patient use. Anyway, the other thing to watch out for is that these are very much dependent on renal function in order to clear the drug. So if you have patients who have renal dysfunction, they're more likely to hold on to that enoxaparin, and you're more likely to see excessive bleeding, bruising, etc. Right? So you have to watch out for that. And so this is where we can either use factor 10A levels, to monitor for that. We do this we do this for just about every patient in the pediatric setting, because a lot of these dosing that we have, a lot of the data that comes from these studies is all going to be in adults. So a lot of times we'll monitor more kind of proactively in pediatric patients. We do a lot of 10A assays there. And then also if you're in very extremes of weight, because again, when you get higher and higher of weight, obviously, the adipose tissue is going to become much more of a predominant function of their weight. And so due to things like volume distribution changes and whatnot that we covered previously, you can have some kind of differences in how well anticoagulated a patient is going to be. So we'll monitor for those patients at those kind of extremes there. So again, if it comes up on a test question and I say patients on heparin, what's going to be the appropriate monitoring parameter? You'd say APTT. But if it said you had a patient who weighed 600 pounds and you're going to give them on Lovenox, what would you monitor? Anti-factor 10A level, right? So it's important to make those distinctions there, because again, if you measured APTT for a patient who's getting Lovenox, may read totally normal, even though the patient's very well anticoagulated, right? So just keep those in mind. Typically less bleeding than heparin and less risk for HIT. Really haven't seen clinically where HIT will develop in a patient who's receiving something like Lovenox. Keep in mind though, that if a patient has a history of HIT, you do not want to give them a low molecular weight heparin. There is that risk for cross-reactivity with those antibodies, and so you don't want to end up causing them to start clotting off. There's one drug we'll see in just a second that we can use instead, but typically, avoid low molecular weight heparins in patients who have a history of HIT. Okay, so this last drug we have here in this kind of heparin kind of based category is called fondaparinux or Arixtra. This one is basically just the 5 pentasaccharide sequence that is necessary for antithrombin 3 and factor 10A to work with this drug, right? So it's just the bare minimum that you need in order to inactivate that. So it has no factor 2A activity, but only 10A. So as such, what would you imagine, which monitoring parameter you're going to look at? Yeah, anti-factor 10A once again is going to be the primary thing we're looking at here. And typically, no monitoring is required. And the other thing is, again, you really need to watch renal function. Patients' renal function declines, they're going to have accumulation of drug, more likely to see bleeding. Got to watch out for that. Very, very low incidence of HIT. In fact, some people will say if you have a history of HIT that you're probably safe to use fondaparinux because it's such a short molecule that has very low likelihood to react to those antibodies, which is kind of a benefit there. But again, you see it a lot used in prophylaxis of clots and cases of hip, knee replacement, for treatment of active clots and like PE, venous thrombosis. Those are all, again, therapeutically, these are all can be used for the same kind of indications, which is nice. Okay, so that were kind of the heparin-based molecules there. Next, we're going to look at what we call direct thrombin inhibitors. These are, again, going to just be IV agents for the most part here. And these are actually based off a product called Heparin, which actually comes from leeches. Does anyone was aware that we use leeches medicinally? Yes. I'll tell you kind of a funny story. Medical leeches are still available on the market. Very rarely might you use these, usually at the behest of a kind of a more eccentric hemonc doc. But basically, it's kept in the pharmacy, which is kind of gross. You think leeches kind of crawling around with your drugs that you'd use for every other patient. They also have a tendency to escape. They like to crawl out of their cage, not cage, but their kind of their aquarium, thank you. They tend to crawl out, and then you just kind of find out what's that little black thing? What's a leech that got out? So we try not to hold on to as often as we can. And in fact, they're pretty expensive. And there's one time where an unwitting pharmacy technician, came in and said, "Man, those things really stink. I'm gonna go ahead and dump them." End up wasting the whole thing down into the toilet. It was a very, very sad day. We ended up losing all those leeches. We had names for them and everything. But now we don't have to use leeches very often because we have these products that are based off that Heparin, that natural anticoagulant that the leeches were producing themselves. So we have 3 drugs here. We have lepirudin, bivalirudin, and an argatroban. Okay, these are basically going to be directly affecting factor 2, and so as such, the monitoring parameter we're going to use is, because they're direct thrombin inhibitors. That means they're only affecting factor 2A. So anti-10A level would look normal, but they are going to be affecting APTT, right? So this is where we monitor that. And these are the drugs we're going to use as an alternative to heparin if you did have someone who had HIT. Basically, when those patients, when you're activating all those platelets, they're at risk for clotting. So we want to go ahead and give them something that's still going to help to work as an anticoagulant, but will not trigger off those antibodies. So this is where our direct thrombin inhibitor is going to be very useful here. Again, the main difference between these drugs is going to be their elimination, where you can see that leporudin and bivalirudin are going to both be renal excreted. So again, not very good for patients with renal dysfunction. You may want to use something instead like ergatroban. And vice versa, if you had really bad hepatic dysfunction, you might use something like bivalirudin instead. Again, most of the time these are used in cases, if you could not use heparin, in cases of like, the patient undergoing surgery or something like that, this is an alternative you could use instead. So again, it's kind of a nice benefit with these. Okay, next up, we have warfarin. Warfarin's kind of a big deal. It's starting to kind of be on the more the descendant side of things, as we have new drugs called these new oral anticoagulants that are coming about. But warfarin is really nice because it's an orally available medication, right? So heparins are no good orally; they get chewed up by the GI tract. The direct thrombin inhibitors are no good. So we have warfarin instead. Warfarin is an orally active anticoagulant. If you're ever curious where the name actually comes from, it comes from this Wisconsin Alumni Research Foundation. So again, a little bit of pharmacy trivia you can impress your friends with. But basically, we did not know, we kind of discovered warfarin on accident, essentially. And it was at this University of Wisconsin, where basically they realized that these cattle were having this hemorrhagic disorder, and realized it was coming around this kind of the spoiled the silage that they were consuming. So we discovered warfarin from that. And then for a long time, we used it as a rodenticide, which means it kills rats. You want to know why it works on rats? Rats don't have a vomit reflex. They end up ingesting this stuff and rat poison, and they can't vomit it up, and then thus they end up basically bleeding out. Not super humane for the rats, I should say, but very effective regardless. And so anyway, so we realized that, hey, this works for rats. It works as an anticoagulant. Let's try it on people. Actually works great as an anticoagulant as well. So you can tell your patient, yes, you're taking rat poison, but that's okay because it's treating you, keeping your AFib from throwing a clot. It's going to give you a stroke, right? So that's kind of the benefits here. There's you'll find that warfarin's a racemic mixture, right, which means it has two enantiomers there. There's the S and the R enantiomer, and basically the S one tends to be much more pharmacologically active, tends to be much more potent at blocking more anticoagulant effects, I should say. And I'll talk about the mechanism here in just a second. That'll be important when we talk about drug interactions in just a little bit, because for a long time, obviously you can't keep a patient on heparin forever. But if you need an oral anticoagulant, this is the go-to drug for decades, right? So this is a very old school drug. You find tons of patients who are still taking this. And so it's really, really important to understand drug interactions, food interactions. A lot of the newer drugs we have kind of circumvent a lot of the issues that we had with warfarin, but we're going to see there's going to be some trade-offs there, because we're going to find that as far as reversal agents go, warfarin has a really good one. A lot of the newer ones do not. So we're going to see it's very much a trade-off of toxicity versus efficacy and convenience. So anyway, the way warfarin works, we're going to call this a vitamin K antagonist. Okay, basically it means it's going to be blocking production of new clotting factors within the liver, and very specifically, it's going to be affecting these vitamin K dependent clotting factors. So it'll affect factor 2, 7, 9, and 10, and then it'll also end up affecting protein C and S, which we mentioned previously, kind of a natural anticoagulant effect, right? So even though it's going to have blocking production of some anticoagulants, predominantly it's going to be more affecting these clotting factors here and helping us to have an overall effect of being anticoagulated, right? Basically, once the liver gets vitamin K in through the GI tract, it's going to have this process where it gets recycled, essentially, right? So you have this vitamin K epoxide, essentially, that will end up getting reduced by this vitamin K epoxide reductase. And then when that occurs, it's able to basically interact with these kind of pro-clotting factors, these not active forms yet, and interact with this. And this is how you get things like prothrombin, right? Prothrombin is factor 2, right? So you're going to see that it'll be able to basically interfere with that. If you don't have enough vitamin K, you're not going to be able to produce these clotting factors, and thus you can have an anticoagulant effect, right? So if you had to think about it, how long do you think these take to work? Will it work immediately, like heparin does? No, that's kind of the big thing, right? So you have to be aware that it does not affect already existing clotting factors that are circulating in the blood. This takes time to work because it has to produce, or has to affect newly produced clotting factors, essentially, by blocking that. So that's the other really important thing to consider, is that it takes time, several days, in fact, before you really start to see the anticoagulant effect. Just another picture kind of showing the same thing. We have this oxidized vitamin K that is going to be blocked. This enzyme is not going to work so well due to this warfarin effect. And notice, we'll talk about this a little bit later, but notice these enzymes here. What are these? These are CYPs. It means that these are going to be the things that basically metabolize warfarin. If you interact with these, you're going to find some big issues we'll talk about a little bit later. But basically, blocking this enzyme is going to prevent us from reducing the vitamin K. It's going to be functionally not very effective, and thus we're going to end up having issues producing new clotting factors. So basically doing that to the rats end up bleeding out and then eventually dying. But we're going to try to strike a nice balance here with our patients, unless, again, you don't like them, then in which case, maybe go crazy with it. Who knows? Just kidding, I don't advocate for that. So anyway, so what we're going to see is when you have therapeutic levels of warfarin, you'll be able to drop these synthesis of cofactors by about 30 to 50% or so, and the activity of those that are synthesized, they actually do get made, are going to be less effective as well, about 10 to 40% decrease there. Again, not working on already produced factors that are floating around the blood, so that means that we're going to have a delay in onset. Again, typically 3 to 5 days before we really start to see kind of peak effects from the warfarin that you're giving them. So you can see here that the different clotting factors have different half-lives associated with them. So you have things like factor 2 has a half-life over 60 hours. So as you imagine, that it's going to be circulating around for quite some time. As it gets degraded down, that's when the warfarin's really going to start to have its effect there. The other thing to note here is that protein C, being a natural anticoagulant, which you can actually see for some patients, is that when you give them warfarin initially, that protein C runs out very quickly, and so you can actually end up seeing kind of a procoagulant effect. So there is some small risk if you start out a patient on warfarin by itself that they could actually be kind of at higher risk for for clots in the very short term. Which is why a lot of times, anyone ever heard of bridging therapy? Where you basically have a patient who's, say, developed a PE or a DVT or something like that. You will start them on heparin on the inpatient side, and then you basically will start them on warfarin at the same time, a few days in, right? So you start them on warfarin, and then by the time their INR gets up to, we'll talk about INR being monitoring there for warfarin in just a few minutes, but once they get therapeutic on warfarin, then you DC the heparin, and then they're just on warfarin itself. Because again, in that short term, they could be kind of more in a procoagulative sort of state, so you want the heparin there around to make sure they don't have any clots. Does that make sense? So if you're bridge therapy, that's why you might see a patient for a few days to be on heparin and warfarin at the same time, essentially. Okay, so again, you'll start to see some effects within 24 hours, and then usually kind of the most kind of peak effects within 5 to 7 days, but usually 3 to 5 days or so, you should start to see the INR start to move, and you'll start to see that kind of equilibrate out. So again, this is an orally administered medication, very well absorbed. You're going to find that half-life roughly, or you get to steady state within about 3 to 5 days or so. And then this is also going to be an important thing where it's highly protein bound to albumin. Why is that therapeutically important? Yeah, so some kind of low albumin, maybe that could increase the free fraction of warfarin. That's one thought. What else? What about drug interactions? If you have other things that are also highly bound to albumin, what does that do to the warfarin? Kick it off, right? Could kick it off the albumin, and then all of a sudden you have a higher free fraction, which can mean it's more active. Because again, anything bound to albumin or bound to serum proteins is active or inactive? Inactive, right? So once it's bound to serum proteins, it's not going to be very useful. But again, there's that kind of equilibration where as you metabolize the drug, more of it will come off the albumin, that happening there. So again, if you had something that came on and kicked that off, now you have more free warfarin, and that can cause kind of a more increased anticoagulant effect. You see more risk for bleeding and whatnot. So anyway, so looking at drug interactions, CYP2C9 is going to be the primary drug interaction we're going to be focused on for warfarin, but also you're going to see that things like 1A2 inhibition or 3A4 inhibition can also affect the less active R warfarin, but that's warfarin's the primary one we're going to be looking at. Warfarin is also not going to be used in pregnancy. It can have pretty significant effects on the growing fetus. I believe it's a technically category D, which means there might be some risk in very rare circumstances, but generally don't use it. This is why we use heparin instead for those pregnant patients. All right. So drug interactions. So we're going to find that things that will decrease the activity of warfarin. This is important to kind of keep these concepts in mind. So if I have an increase in the amount of vitamin K available in the body, what does that do to the effects of warfarin? Should decrease it, right? Because as I have more vitamin K that comes in through the GI tract, I should have more vitamin K available to start that process of producing new clotting factors. So you should see that warfarin becomes less effective. Okay. On the flip side, if I were to decrease, say, vitamin K synthesis or vitamin K intake, what should that do to warfarin's effect? Should increase it, right? So that means you're going to be more likely to see bleeding and things like that. So again, diet is going to be super, super important with warfarin. We have to be so careful when you're dosing these patients, and education is paramount. This is why in a lot of cases you may see, if you work in like family practice clinics or things like that, a lot of times we're going to have pharmacists run anticoagulation clinics, and we did that a lot when I was on rotations. In fact, if the pharmacy student graduated and couldn't dose warfarin very well, they must have been sleeping through rotations or something, because everyone got a chance to do that essentially. But because you guys could focus on all the other health issues, we could focus just on this one narrow issue, and that kind of goes to show you just how important it is, because it could be either life-threatening on either end if it's not, you don't have enough warfarin around, or if you have too much effect essentially. So looking at uptake and metabolism of oral drugs or vitamin K, this can all have decreased activity. So if we were to have, say, CYP2C9 inducer, if we were to induce CYP2C9, what would that do to warfarin metabolism? It would increase metabolism, which would cause the effect of warfarin to decrease, right? Because there's less warfarin around, right? Or if I were to have too much vitamin K intake, and again, think about green leafy vegetables as typically having the highest content of vitamin K. So what are some green leafy vegetables you can think of? Spinach is a big one, right? So Popeye would have been very difficult to manage on warfarin. I can tell you that much right now. What else? Kale's another big one. Collard greens. Arugula, okay, that could be one. It's not the top one off my list, I'm sure it's on there. Also think about if people eat like liver. Some people do eat liver. I don't know why, but it's pretty gross. It has a lot of vitamin K content to it, right? So again, this is good patient education. And when I did my rotation working in a Coumadin clinic, basically it was in Putnam County. And so Putnam County is a pretty rural area. Anyone know where that is? Exactly. No one really knows where that is, right? Think about if you see like Gainesville on the map and St. Augustine, we're kind of right in the middle there. So like kind of podunk, middle of nowhere. Their diet was pretty southern, right? So they eat a lot of collard greens, they eat a lot of kale and things like that, usually growing out of the back of their, their yards. And so again, they had to be really educated very well on this. The point being, can they eat any green leafy vegetables? Should they be told just to hold off completely? No, because I mean they're healthy vegetables. They should be able to eat that. The point is to keep it consistent, right? Consistency is the key with the warfarin for patients to be successful. The only reason why I go off this, I talk about this so much, is just because again it is so patient education intensive. It's important to have all these points down. But consistency is important. You don't want them to be like, I'm going to be super healthy. I'm going to eat all spinach diet for the next week, which will cause their warfarin effect to go down, right? More vitamin K means warfarin's less effective, and then all of a sudden they're like, nah, that spinach diet was totally gross. I'm gonna stop doing that. And they have no spinach whatsoever. Then the vitamin K effects or their warfarin effects are gonna go through the roof, right? So they need to be consistent with it. Say, hey, if you have say 3 meals that have collard greens in it a week, keep that about average, and you should be okay as far as your monitoring goes. So then other things, anything that's going to be affecting clotting, the actual synthesis of clotting factors, that can also affect warfarin's thing here. So as I mentioned, CYP2C9 inhibition, that's going to be a big one, big drug interaction that will lead to increased warfarin effects. So again, more warfarin sticking around, the more likely you are to see the kind of anticoagulant effects there. I mentioned protein binding interactions already. And then anything decreasing vitamin K intake, right? So either intake or synthesis within the GI tract. And that's another important point here, which I think we talked about this in physio a little bit. But gut bacteria in the colon are really important for helping to synthesize vitamin K as well. That's where we get a lot, big source of vitamin K for absorption. So if you lose that, and which is why you can see certain interactions with antibiotics. If you would have, say antibiotics, especially things like, Bactrim's a big one that causes interactions here. You'll see clindamycin also, that has a big effect on gut bacteria. If you get rid of that, less vitamin K gets absorbed, you're going to see the warfarin effects are going to increase there, right? The other big thing is going to be looking at liver function. As patients' liver function starts to drop, they're obviously going to be making less clotting factors, and so that's going to be making warfarin more and more effective, essentially. And again, when you think about how do you monitor for the function of the liver, you think LFTs, right? You think LFTs are the thing you look, because this is liver function test. It should tell you how good the liver's functioning. Not necessarily. The thing you really want to look at is their INR, right? We're going to find that INR is going to be a direct function of these clotting factors, and if your liver starts to go kaput, you're going to see that the INR is going to start to climb. So this is a big thing we'll look at when we look at Tylenol overdose patients, for instance. Everyone knows that the main toxicity with Tylenol, especially in overdose, is liver dysfunction, right? That's why I always tell you don't take more than 4 grams in a day, because you're going to see liver toxicity. Thing we'll look for, if a patient overdoses on a huge amount of Tylenol, we'll look at their LFTs. Their LFTs can start to climb, but eventually they're going to start to decrease. As you kill off another of those hepatocytes, they stop producing liver enzymes, essentially, and so that doesn't really tell you how well it's functioning. Once I start to see a patient's INR start to climb, that's where I know the liver is really in trouble. And so basically it's kind of showing us the same thing. Patients with really severe liver dysfunction do not produce clotting factors as well. That's warfarin's going to be working more effectively, right? More risk for bleeding. So the monitoring parameter I mentioned is we're going to be looking at PT-INR, this international normalized ratio. Anyone know why we look at PT-INR? Why we look at INR specifically? Because it really depends on the lab that you're looking at. Different reagents, different kits, things like that can all affect basically what type of PT reading you're going to get. And so essentially what we're going to be looking at is that PT of the patient versus a reference level. And then they have this sensitivity index you multiply it by. This makes sure that no matter what lab you go to, they're all reporting basically the same INR essentially. Now, typically, INR being a ratio, what's a normal INR? 1, right? 1. So if you had no anticoagulant effect around, you would have a normal ratio of your patient, INR PT would be the same as the reference PT, essentially, right? So an INR of 1 is considered normal. we want our patients who are on warfarin to typically get up to a range of usually 2 to 3. There's some cases where we shoot a little bit higher, like 2.5 to 3.5, but again, relatively low numbers we're looking for here, right? So I think 2 to 3 for most patients. Anyone know we might shoot a little bit higher? I'll mention that in a second. So mechanical heart valves are going to be the other big thing you're going to be looking for. So again, I mentioned anytime you're putting foreign material into the body, you're more likely to cause clots. Well, not just like a bare metal stent being put into a coronary vessel, you can see clots forming there. Same thing if you put a mechanical valve, that's going to be much more likely to cause a clot. We need even more anticoagulant effect. So we shoot a little bit higher for those patients, but typically 2 to 3 is good for most people. So you think about a person who has AFib, you're just doing it for prevention of stroke, 2 to 3 is typically good for those kind of patients. They also have warfarin resistance. You're going to find that certain patients will have different genetic predispositions to being more resistant to warfarin. They tend to have issues where they're not going to be able to get their INR, or they're going to just be more resistant to the effects, or you may need to drive their INR a little bit higher in order to have good anticoagulant effects there. And then some patients are going to be more sensitive to warfarin. You can see there can be different polymorphisms. You guys familiar with polymorphisms? What are those? Basically just changes in the genes, right? So we mentioned like acetylators. Remember that we talked about hydralazine? If you had like a slow acetylator, that caused what to occur?
Shorter half-life.
Longer half-life, right? A slow acetylator. So you're going to have that lupus-like syndrome that kind of occurs, that rash that happens. So again, that's a polymorphism, right? It's going to be basically a change in that gene that makes it work either more effective or less effective. Same thing happens for warfarin, especially in these 2C9 alleles. Essentially, you can have some that are going to be very slow working, some of them may be completely inactive, and that can lead some patients to be more prone to have they might be more sensitive to warfarin, right? Basically, they won't be metabolizing warfarin as well, so the levels will climb up, and that's going to be more effective at blocking vitamin K, right? You guys mind if I just finish up and not give you a break?
Nope.
Yep, I figured. So anyway, so you can see like 10 to 20% of Caucasians may fall in this category. Less than 5% of African Americans though. So it just depends on patient population you're dealing with. And again, you're always monitoring the INR to look to see how kind of they're being affected by that, right? So again, usually you'll have like a standard dose you'll start patients out on. You may say like 5 to 10 milligrams a day. Typically, because it's a long half-life, you only dose it once a day. But and when would you want to monitor INR again? When do you recheck it? The next day, 48 hours, 72 hours, a week. Takes a couple of days for it to really kick in. So usually around 72, maybe 96 hours or so is when we're going to recheck on that INR. Doing daily checks isn't super effective because again, if it takes 2 or 3 days for that really to start to kick in. So we give it a couple of days, have the patients come back in, recheck their INR, and then change their dose, whatever we have to do, and then we'll get to hopefully that 2 to 3 range is what we're shooting for. Obviously, bleeding is going to be the biggest risk that we're watching for. So again, know the signs and symptoms. What would you, if you had to educate a patient on signs and symptoms of bleeding, what would you watch for? Tell them to watch for. Bruising is a big one. Yep. What would be a sign of like a GI bleed? Yeah, blood in the stools. Yeah. So what type of blood would be indicative of like say like a lower GI bleed? Yeah, bright red, right? It was upper GI bleed. Yeah, dark tarry stools, right? So again, think about all these things you let your patients know to watch out for as far as signs. Obviously, they're having like any hemoptysis or hematochezia, anything like that. Obviously, those kind of major signs they need to be aware of, so that way they know if they need to come back in and get checked out more kind of immediately or so. Now, if you have a patient who's got an INR within the typical therapeutic range, say 2 to 3, or even say 2.5 to 3.5, as mechanical heart valve patients, less than 5% of major bleeding associated with that, right? And so it's interesting when you read those studies. Again, kind of going back to EpiBio. Make sure that you look at those definitions when they mention like major bleeding versus minor bleeding, because they might have some bleeding definitions on there like that sounds pretty major, even though they're considering a minor thing. So always make sure your definitions are kind of more explicit with that stuff. Anyway, as your INR starts to climb, say you get above 4, increased risk for cranial hemorrhage. Obviously not good. And then once it starts to get above 5, you start to see a risk for kind of just bleeding all over essentially. But obviously stroke is going to be one of kind of the major things we're really concerned about there. Now the antidote, obviously we could give would be what? Vitamin K, right? So if I'm inhibiting vitamin K by giving warfarin, I can just basically give them supplemental vitamin K and that should fix it. Now, is that an immediate fix? Why not? Yeah, the liver has to produce new clotting factors based off that vitamin K that I'm introducing. So it's not an immediate fix. If I really needed to fix a patient, basically what I could do is I could either give them fresh frozen plasma, which already has clotting factors in from donated sources, or I can give them cryoprecipitate, which is basically a more kind of concentrated form of that essentially. That will basically give them and will replenish their clotting factors and help them to basically clot off any of those bleeds that they're actively having, right? And so if I have any kind of serious bleeding, so if I had a person who had an active GI bleed or a stroke or anything like that, basically I would give them fresh frozen plasma plus vitamin K, so I can kind of overcome the warfarin effects and fix their kind of immediate bleeding issues to begin with. And so big things to watch out for is, just be aware of that time delay there, that if you need to really fix them, give them fresh frozen plasma is the way to do that, right? So this is the nice thing. This is really easy to reverse if you had a patient coming with a major bleed. We're going to find some of the newer agents we'll talk about in a second do not have that same convenience associated with them. So even though INR, warfarin's a pain in the butt to get them to therapeutic INR and keep them there, from a dietary standpoint, from drug interaction standpoint, it is infinitely better, I think, in my mind, to be able to fix them if they have a major head bleed. So, because again, you're giving this to elderly patients. What are they at risk for? Falls, right? They fall, hit their head, they could die from that, right? So I can fix that pretty quickly from a warfarin standpoint. Some of the newer ones, we'll see that's not going to be the case necessarily. Obviously, birth defects, so again, don't give this to any pregnant patients. And also, you can end up seeing, you'll see this in patients who are on warfarin chronically, that is kind of the skin necrosis that occurs. Basically, have this kind of dark purple blotchy marks under the skin that can develop over time. It's not necessarily evidence of active bleeds or anything like that. It's just kind of the skin necrosis that happens due to deficiencies of things like protein C and S. Okay, so we mentioned warfarin, very highly diet dependent, so you have to keep the vitamin K intake very consistent. You have to do frequent monitoring of INR to make sure they're staying within range. Multiple drug interactions, things that inhibit 2C9, things that induce 2C9, but the benefit is it's easily reversible. Okay, so we have a couple alternatives. We call these new oral anticoagulants, or NOACs, if you ever hear that. Those are going to be the kind of the newer drugs. Again, these are all brand name drugs, pretty expensive, probably introduced within the past 5 to 7 years or so, I would say. They're starting to get some use here. So the first one we have is called Dabigatran, or Pradaxa. This one is going to be an oral direct thrombin inhibitor. So this is very similar to Argatroban and Leparudin that we mentioned before. It only works basically to block factor 2A from being very effective. So it doesn't do anything to production of clotting factors. It basically just directly inhibits it. So this can be useful for things like DVT, PE, atrial fibrillation. A lot of patients who are coming into the hospital are getting, say, started off on something like Warfarin. Started off on like Lovenox or Heparin. They get converted over to one of these before they get discharged from the hospital. The benefit here: how long do you think these take to kick in versus Warfarin? A lot quicker, right? So it doesn't have to. You don't really have to bridge for nearly as long as you would with something like Warfarin, which is another benefit. Get them out of the hospital sooner. Cheaper stay, right? It's always going to be kind of one of the benefits from the hospital standpoint. The other big thing: no routine monitoring. You don't look at APTT, you don't look at PT INR, you don't look at anti-factor 10A. None of those really get affected that well or that consistently. So we actually don't really do any monitoring with this one. So that's kind of the benefit. But the other problem is that if you did have bleeding, there's no good way to reverse that, right? So I can give them FFP, I can give them fresh frozen plasma, I can give them cryoprecipitate, but the problem is all that factor 2A that's in the FFP, guess what? It gets inhibited just like all the other factor 2 that the patient already had to begin with, so it becomes less effective. This becomes much more difficult to reverse. And in fact, what's interesting is we actually produced a monoclonal antibody designed specifically to bind to dabigatran and render it inert. So this is very similar to what we saw with that Digibind or Digifab. Remember we talked about that as being an antidote for digoxin? This is a new drug that we use to basically bind that up and prevent it from having a more anticoagulant effect. What's interesting, though, is that this company that made dabigatran, guess who also made the antidote? Oh, weird, huh? The only antidote you have for this drug happens to be the same company. Interesting. Not that I'm cynical, just saying it's interesting fact. Big Pharma, yep. No good. Especially those pharmacists are the worst. Anyway, so you have to be careful with these newer anticoagulant drugs, so they're not going to be as easily reversible as warfarin is. That's the big draw there. This one is also renally excretus. You have to watch out for patients who are on dialysis because that can pull it off. You have to watch out for patients who have renal dysfunction. To me, hold on to this drug and be more likely to see bleeding occur there. Okay. Factor 2A inhibitor. These next ones we're going to talk about rivaroxaban and then also apixaban are going to be factor 10A inhibitors. Okay, so this works more similar to fondaparinux as we talked about previously in kind of that heparin category of things. So it's an oral factor 10A inhibitor, again, used for things like DVT, AFib, PE. It can be used for the same indications here. And again, no routine monitoring. So that's the other benefit. You're not monitoring PTINR. It's much more easy. I think about kind of like the ideal patients for this are going to be like younger patients who don't have a risk for falls, who are pretty busy with, you know, their work life or social life, things like that. They don't need a lot of monitoring. I think about patients who, I think about young ladies who are on birth control. They're at risk for DVTs and PEs. This is a really good drug for that. It's like a new one nurse who developed kind of a just random DVT or developed a PE at work actually. Ended up having to go, you know, get that taken care of. She was on Lovenox for a couple of days, and then they actually switched her over to Rivaroxaban, and so she's able to kind of basically go back to her normal life. She was young, otherwise healthy. No risk for falls, really wasn't a big risk for bleeding. She was kind of a perfect candidate for that. So this is the type of patients I like to think of as being better candidates. Anyway, obviously bleeding here, you're going to find that the 10A inhibitors respond a little bit better to things like protein, what we call prothrombin complex concentrate. This is different than fresh frozen plasma. This is basically just going to be the clotting factors specifically, and includes things like prothrombin factor 2, right? So this is nice because even though you don't have the 10A activity really, you can bypass it by just having that 2A activity. So that's, again, can kind of overcome that. So it's kind of the nice thing there. You can give that drug and help to reverse the 10A inhibition. Again, renally excreted, but watch for dose adjustments. These might be things that change over time, so you might need to look for that to make sure you're dose adjusting it appropriately. Apixaban or Eliquis. This one I'm starting to see a little bit more commonly being used again as an alternative to Warfarin. Same indications you'd use it for any of these other, you know, Dabigatran or Rivaroxaban. And again, no routine monitoring needed. So it's a big benefit here. This one, although is interesting because it is metabolized through CYP3A4, so you do need to watch out for those drug interactions, right? If you have an inhibitor, you're more likely to see bleeding, right? Because you're preventing metabolism of the drug, right? So again, watch out for that. Okay. Any questions on that? So kind of keep in mind how you might use these different anticoagulants. You know, it makes sense. You might see, you know, heparin along with warfarin for a short time. You think about things like bridging therapy, but like the newer ones, you don't really need that quite so much. And in fact, I'm starting to see some newer literature, and this is, you know, not reflecting guidelines necessarily, but I'm starting to see new things where they're actually patients who are relatively young, have few comorbidities, are actually coming in for things like DVT or PE. They're actually just starting them on these newer oral anticoagulant drugs and just sending them home on that. They actually never get put on heparin in the first place. So you might see that change as time goes on, where they'll just get started coming to the ER with the PE. They just give you a pill and you're set, right? So that's one of the kind of the interesting things that are changing with these as time goes on. But any other questions? Okay, so we will start up the chemo stuff tomorrow, and then again, like I mentioned, next week will be the review, and we should be good. So have a nice rest of the day.
Thank you.